Hello, hello, hello. Anybody from organizers?
Sir, good afternoon.
Good afternoon. May I know who is there?
Sir, I am organizer. I am
Oh,
from Three Dot
okay,
Life Science Private Limited, sir.
okay. So, what is your name?
Anand.
Okay, Anand. Okay. So, can I share and see my slides? Hello.
No, sir, no visual. Sir, your slide is not visible, sir.
No. Can I share? I have not shared. Just can I share now?
Yes, sir. Yeah.
Okay. Is it visible now?
Yes, sir.
And let me see the full presentation. Full presentation is also there.
Yes, sir. Yes, sir.
And change, slide changing, slide change is there or not?
Yes, sir. Changes,
So
sir.
now it is working okay.
Okay, sir. All fine, sir.
Yeah, so that's why I joined little earlier to see. Okay, so
I also joined little earlier to say hello to you.
sir, good afternoon.
How are you, sir?
Absolutely fine after a very long period.
Yes, definitely.
I've seen your pollution and health.
Yeah, the book has come up very good.
Yes. We have also written one chapter on pollution and diabetes in RSSDI.
Yes. Dr.
Yeah.
Bansi Sabu has contributed pollution and diabetes in our book. So
Yes.
you send me your postal address.
Okay.
So I will
Sure.
send you the hard copy.
Sure. Thank you. I'll send immediately after this
Okay.
for
Okay.
sure. So Anand, when you will start?
Sir, 3 p.m., sir.
Okay. So
2 minutes left.
yeah, but we have to wait for the stalwarts.
Yes, definitely. To
Professor Tiwari.
formally initiate.
Yes, for sure. Uh, I'll be giving you the little bit of different perspective of the classification. I mean,
Mm.
the usual classification we see because we have witnessed Dr. Vitul for last so many years since Dr. Bajaj was the head of WHO revised committee on classification on diabetes. I don't know whether you
Mm.
remember it or not. He was the first Indian who was the person who had uh, the classification for diabetes in WHO revised classification in 1986.
Oh, great.
Yes, I was
Mm.
also at that time there and I knew everything, all the details about everything.
That is very good.
Yeah, so since then we knew about so many newer things, and he actually advocated for the first time the FCPD at that time. They included
Okay.
PDDM and FCPD, which was
Mm.
basically they classified a new classification from India. But unfortunately, later on, the WHO has removed this
Mhm.
class of diabetes.
But I think Indians must have different classes of diabetes as compared to the Western population.
Yeah. Now Dr. Mohan
So,
has done. I'll be giving
yes.
you that brief also clusters.
Yeah, yes.
Yeah, I'll
Because I
give you.
attended Dr. Mohan's lecture.
Yeah,
He
yeah,
was
yeah.
very
Same.
specific and,
Yeah,
identifying the Indian specific clusters
I,
which are
I,
not.
I will
Yes.
include. I have
Yes.
already included that.
Okay.
Dr. Mohan's thing, because I was also involved as a principal investigator for ICMR in DAB,
Okay.
and I'm also involved in most of the papers of Dr. Mohan
Mhm.
as an author. So yeah. So I hope this will be an exciting thing today.
Definitely, definitely.
Yeah.
Because once you have classification, only then you can proceed with the treatment.
Absolutely. Absolutely. You
So
are
this is the
under
basis. This is the basis for initiation of any treatment, rather.
absolutely. Absolutely. And how about your Mapicon?
Mapicon progress is going on good. We
Yeah.
will start next month to invite the speakers. So
Okay.
dates have been fixed from 18 to 21st.
Okay.
So because last time it was with Diacare Con, it was overlapping. So this
Yeah.
year I asked Bansi what is his date. So
Right.
so we
Right.
have kept it 1 week before.
Okay. Okay.
So otherwise again it would have overlapped.
Yeah. Vinay, your name is little different down. Your name comes here as Sanjay Kumar.
Sir, may I request you to start the class as the time is already 3?
I can start, but I have to wait for the stalwarts. Dr. Sanjeev Maheshwari is already here. So, because it is the API program and ICP program, we have to formally wait for Professor Tiwari, Professor Puneet Saxena. So, this is a formality we have to do. Otherwise, I am ready.
Good afternoon, Dr. Arvind sir.
Yeah, good afternoon.
Very good afternoon. So let me introduce you first because the class has to start in time. Dr. Kamlesh Tiwari has delegated his duties to me. I
Okay.
welcome Dr. Arvind Gupta and all other persons on the dais. And it is the endeavor of API ICP program for a short course. It's a very innovative thing, and one has to do the short courses for learning as much as possible in very limited time and with limited resources. That is why the idea of these virtual short courses has been taken care by our learned and enthusiastic and dedicated Dean ICP, Dr. Kamlesh Tiwari. For this, this is the third class, I think, for the diabetes short course. And we have a learned speaker, Dr. Arvind Gupta. He is a very senior consultant of Jaipur, and he is very active in academics, in field of research as well. He has many research articles, original research article to his credit, including various research articles which are being sponsored by the ICMR and other international forums also. I request Dr. Arvind to please start the class.
Thank you. Thank you. I'll share the slides first. Okay, my slides are in the presentation mode.
Yes, sir.
Okay. Thank you, Professor Sanjeev Maheshwari, for the kind introduction. And let me congratulate Association of Physicians of India and the ICP for starting a beautiful short course, certificate course on diabetes. And I also acknowledge Professor Puneet Saksena's contribution in designing this course. So, and Professor Dr. Girish Mathur, Dr. Tiwari, and all the executive committee and the office bearers of ICP and API for designing this course and giving me the opportunity for the third module, which is the included classification of diabetes. Dear friends, right at the outset, my students are there, postgraduates are there, and this is basically a learning for all of them because I know Dr. Bajaj has started the first head of WHO revised classification in 1986. He included and he wanted to include the FCPD and protein deficiency diabetes mellitus, which was very specific to Indian continent. At that time, it was included. So I knew the intricacies of classification of diabetes since then. So let us see, these are my disclosures, but nothing special about today's course. Dear friends, this is nothing new for all of you. Diabetes is a global emergency, and almost you can say it is a fastest growing global emergencies in the 20th century, along with hypertension, along with coronary artery disease, along with the obesity. Around 537 million people of working age, that is very, very significant, who have already diagnosed or undiagnosed diabetes in 2021. And at present, around this much of, if you see here in last and the next future expectation of diabetes will be around 783 million population in 2024 45. So this is the projections of the numbers. I again need not to emphasize the seriousness of diabetes prevalence in Southeast Asia, especially when we see that 1 in 11 Indians, around 90 millions, living with diabetes. Adult with diabetes is expected to reach around 130 million by 2030. 1 in 2 adults living with diabetes are undiagnosed. This is a very, very special concern for all the countries in the world. And of course, the mortality and the expenses are enormous when the person is suffering from diabetes. Our own country has experienced the very high number of diabetes in the world, second to China. But now I think with the newer ICMR and statistics, which says that India is equivalent or even more than China. So ICMR in diabetes study was the first study, largest study from our own country. I am one of the author for this ICMR in diabetes study. I was the principal investigator for Rajasthan. And this study for the first time says that the around 46% diabetes, type 2 diabetes are under age 40 years. So our young population is also coming with the diabetes. 40% diabetes between the age of 41 to 50 years. See the situation in the younger population. Of course, the comorbid conditions along with the diabetes is hypertension, obesity, dyslipidemia, and coronary artery disease. And of course, diabetes is a cardiometabolic syndrome, or I can say cardiorenal metabolic syndrome. So it has a very high prevalence along with the type 2 diabetes. So dear students, let me first clear what is the diabetes. It is a complex metabolic disorder. It is not a simple hyperglycemia. And this hyperglycemia is due to several anomalies. Of course, basic pathophysiological insult is either the insulin secretion defect or it is the hyperinsulinemia or insulin resistant defect. So it involves so many metabolic aberrations in the body, including carbohydrate, fat, proteins, metabolism. And dear friends, this is a progressive disease. It has a complex pathogenesis. So if I can summarize right at the beginning, that type 1 diabetes is an autoimmune destruction of beta cells, and type 2 diabetes is either insulin deficiency or insulin resistance. So ultimately, this hyperglycemia affects the most of the parts of our body, which includes the adipose tissues, which increases the most lipolysis, the free fatty acids is circulating in the blood, which also leads to insulin deficiency. It also affects the muscle where the enhanced protein catabolism occurs, and because of this, again, insulin deficiency occurs. On other side, liver is also a very important site where the glucogenesis in the form of increased hepatic glucose output, it also contributes to diabetic ketoacidosis. And hyperglycemia through the kidney, I'll also give you the little details about that. It actually causes ketonuria and glycosuria, which increases the polyuria, causes dehydration, and ultimately ensues the diabetic coma. So it is the core defect is not only the insulin deficiency or insulin resistance, dear students. Hyperglycemia can be because of alpha cell disease, the increased glucagon secretion through the alpha cell. And nowadays the people say that diabetes is primarily is not a beta cell disease, but it is an alpha cell disease. There are several other organs also involved in the hyperglycemia. That is one of the important is the gastrointestinal tract where the incretin defects are there. And because of the incretin defect, the hyperglycemia occurs. Adipose tissues, we have already seen increased lipolysis. The muscles are also involved where the decreased glucose uptake occurs. The liver is a very, very important site for increased hepatic glucose output and also causes the hyperglycemia. And dear friends, our kidneys are also one of the important site where the sodium glucose transporters are located in the primary proximal tubule, where the defective reabsorption can lead to hyperglycemia. So this is known as very typical, known as DeFronzo's ominous octet, and there are several other defects these days also contributes to hyperglycemia. So let us see what is the newer classification I can say of the diabetes, because several times after 1986, the several times WHO, ADA, American Association of Clinical Endocrinology, and several other associations have revised the classification of diabetes. So what is the basic classification? The basic classification includes the first important thing, the type 1 diabetes, which accounts for around 5 to 10% of diabetes cases. Then it is the type 2 diabetes, which is the most of the people we come across are the type 2 diabetes, which accounts for around 90 to 95% cases of diabetes. Then the important cases are the gestational diabetes mellitus. Dear friends, we have to be very careful when the pregnant lady comes to us, then we have to actually see the gestational diabetes mellitus. We have to evaluate the glucose in every pregnant lady when she encounters for the first time to the gynecologist or even primary care physician. And then there is a new class of diabetes, which is known as secondary diabetes, that may be because of several comorbidities, several endocrinopathies, or these days it is because of the drugs or chemicals, or maybe because of the post-transplant. So this is the basic of the classification of diabetes, the 4 classes. But the WHO has devised the classification as for the etiology or etiopathogenesis of diabetes is concerned. So according to WHO, the classification ensures the type 1 diabetes. It is a separate entity which has an autoimmune destruction of beta cells. Type 2 diabetes is a different entity where the several aspects of diabetes occurs, including insulin deficiency and insulin resistance. Then the third important class WHO has included, known as hybrid form of diabetes. And what is that? It is the slowly evaluating immune-mediated diabetes in adults, which is previously termed as LADA, or latent autoimmune diabetes of the adults. Then the ketosis-prone type 2 diabetes, again the previously termed as Flatbush diabetes. I'll give you little details of these LADA and the Flatbush diabetes just little later. So this is a hybrid form of diabetes where the different class of diabetes is there. Then very important types known as other specific types, which includes monogenic diabetes. Monogenic diabetes means there is a defect of beta cell function and insulin action. And this is the only diabetes in all the classification of diabetes, which is a pure genetic basis of the diabetes known as monogenic. Of course, then if you have the diseases of exocrine pancreas, including the acute pancreatitis or the infections, then the endocrinopathies also can lead to diabetes, including the pituitary causes of diabetes, including acromegaly and several other endocrinopathies, which can lead to diabetes. Then a very specific class of diabetes known as drug or chemical induced. One of the important drug which we know we have used in COVID, that is the steroids. But there are certain diuretics and certain other drugs can also lead to diabetes. One important drugs which we use in HIV treatment, again, this is antiretroviral associated diabetes known as ARAD. Another is the transplant diabetes, post-transplant diabetes. So there are several drugs which can lead to diabetes. Infection-related diabetes, which we have known, we have already experienced in last 2 to 3 years during the COVID period, and otherwise also day-to-day experiences, we see the infection-related diabetes, which is a short-lived most of the time. Then there are uncommon forms of immune-mediated diabetes. Also there, I'll also give you little details about that thing. And there are several genetic syndromes, sometimes associated with diabetes, also can lead to diabetes. Dear friends, there is another class of diabetes where you cannot classify amongst the above, which I have already enumerated to you. This is known as unclassified diabetes. It is a temporary category which is used when diabetes does not fit into any other category. So this is WHO has said that, okay, you can have a separate class of diabetes. And then very important class of diabetes is hyperglycemia, first time detected during pregnancy. That is, can be diabetes mellitus in pregnancy or gestational diabetes. Either the ladies who are already having type 1, type 2 diabetes before pregnancy, or the ladies who experience for the first time diabetes during pregnancy, which is known as gestational diabetes mellitus. So with this overview of classification of diabetes according to etiology, according to WHO, now I'll give you little details about the type 1 diabetes. So what is type 1 diabetes? It is an autoimmune disorder where the destruction of beta cells takes place, and usually it is T cell mediated. So ultimately, once your pancreatic beta cells are destroyed, the reason may be several things which till date we are not having very specific mechanism why these pancreatic beta cells are destroyed in type 1 diabetes. So, but ultimately it leads to insulin deficiency, and in the downline, it leads to severe hyperglycemia and severe micro and macrovascular complications. So the autoantibodies which are included in type 1 diabetes can be because of the GAD antibodies, which is very, very common thing, which also we as a biomarker for diagnosis of type 1 diabetes. Sometimes we take this biomarker as a diagnostic marker. So it is a glutamic acid decarboxylase autoantibodies, which is typically known as GAD65 antibodies. Another antibodies involved in type 1 diabetes is islet cell autoantibodies. Another is autoantibodies to the tyrosine phosphate, which is IA2 and IA2 alpha. Insulin autoantibodies are also involved. So there are several immune mechanisms which lead to destruction of the beta cells. And also very important, recently has been diagnosed as autoantibodies to islet islet specific zinc transporter isoform 8, which is known as zinc T8. So, dear friends, we use most of the time, there are several labs in India which can give you the islet cell antibodies also, but commonly we employ the GAD65, which is present in 80% of type 1 diabetes population. So it is an important marker for the diagnosis of type 1 diabetes. But there are several stages of type 1 diabetes. Stages, it doesn't mean the severity of diabetes, but of course, yes, stage 1 when the patient is having autoimmunity, presents normal glycemia most of the time, and they are pre-symptomatic children. And diagnostic criteria is just multiple islet autoantibodies, but there is no IgT or IfG. Stage 2 is where the dysglycemia is present. Again, it is a pre-symptomatic, and most of the autoantibodies are involved in the glycemia. But there is a frank type 1 diabetes, and the patient, full-blown type 1 diabetes, is having overt hyperglycemia. And most of the children are symptomatic. Most of the time, they come into the unconscious or semi-conscious state to the hospital. And now it is because of the full-blown autoantibodies may become absent at that time is here, and diabetes is diagnosed with the standard criteria, which we all know very well. So what is the pathophysiology? I just told you we have not encountered any specific mechanism, but yes, type 1 diabetes is an autoimmune disorder, and it is most of the time T cells are involved in the destruction of beta cells. So the result is actually causes insulin deficiency, severe hyperglycemia occurs, and there are several environmental factors which can trigger the type 1 diabetes. So probably we don't know those type of things, but several infections can be one of the reasons for the genetic and environmental factors are also there. But the important aspects of type 1 diabetes, dear students, there is an increased incidence of other autoimmune disorders along with type 1 diabetes. We also see this type of common autoimmune disorders like myasthenia gravis, like Addison's disease, celiac disease. Sometimes we find very commonly associated with type 1 diabetes is the celiac disease. Of course, other autoimmune disorders like pernicious anemia, autoimmune hepatitis, Hashimoto's thyroiditis, Graves' disease, dermatomyositis, and autoimmune gastritis can also be there along with type 1 diabetes. So, dear friends, type 1 diabetes is a separate entity which usually occurs in children, and the important mechanism is the autoimmune destruction. Then one important class you have to remember, dear students, is the latent autoimmune diabetes of the adults, which is commonly known as LADA. And what is LADA? It is an autoimmune diabetes at adulthood. And what is important thing is that immunologic and metabolic features are similar to type 1 and type 2 diabetes. Still, it is different. And why it is, how it is different, we'll see just a little later. But early diagnosis of LADA is very important, because if we do not diagnose LADA at the earliest, then we'll see the severe micro and macrovascular complications later on. So just give you the glimpse of LADA. It is very common. The age should be greater than 35 years. The positive autoantibodies to islet beta cells are always there with the LADA. And usually these cases or these diabetes cases, they have the insulin independence for at least in the initial 6 months after the initial diagnosis. So most of the time what we see, we treat with the anti-diabetic drugs initially, but later on the destruction is so fast that within 6 months these patients will require insulin for their management. So initially, yes, for a few months, the patients can be very well treated with their diabetes. But I think the best thing is to, if we diagnose the LADA at the earliest, insulin is the right treatment for the LADA. Then comes to the very common cases or common classified diabetes, which we see on a day-to-day basis, is the type 2 diabetes. Right at this point of time, because the students and postgraduates are there, the nomenclature, if you see here right from the beginning, it is the numeral, it is the type 2, it is not the Greek or Roman 1 or 2, it is the numeral. So WHO has clearly said, ADA and all other associations clearly said that if you want to write type 2 diabetes, means you have to write the numeral of type 2, not the Roman one. So that is one important thing I want to specify here. So the type 2 diabetes is basically a non-insulin dependent type of diabetes. This is the earlier one. Earlier means initially most of the type 2 diabetes are do not require insulin for their management. Adult onset of diabetes usually occurs in the after 20-25 years of age, and this is very common variety of diabetes which occurs in 90 to 95%. What is important aspect is there, they have the two types of basic causes for type 2 diabetes. Either there is a beta cell dysfunction or decreased insulin secretion from beta cells, or there is a hyperinsulinemia or insulin resistance at the skeletal level, adipose tissues, or the liver. So diabetes, type 2 diabetes per se is a slowly progressive disease. And most of the time, initially, it is asymptomatic most of the time. That's why the people do not care their management in the initial years. Dear friends, the classic symptoms, which is known as osmotic symptoms of the hyperglycemia, is the polyuria, polydipsia, the weight loss, blurred vision, growth impairment. But most of the time, the symptoms are so vague that we are not able, or even people do not understand that these vague symptoms can be symptoms for type 2 diabetes. So initially, if I can see the type 2 diabetes is basically is because of either genetic susceptibility, where the we don't know, it is a heterogeneity, obesity, sedentary lifestyle, several environmental factors are there which can lead to either beta cell dysfunction or it is the insulin resistance, ultimately lead to hyperglycemia or type 2 diabetes. Dear friends, this is the most important part of my presentation today and the understanding of type 2 diabetes. So even if you see the midline here, when the diabetes occurs for the first time or the patient comes to us as a full-blown diabetes for the first time, even 5 to 10 years before, the changes starts. So it is not the first time the patient comes to us as a diabetes patient. The 40 to 50 or even more than 50% beta cells are already lost. Patients' insulin resistance or hyperinsulinemia starts even 5 to 10 years before the onset of diabetes. That is the most important aspects. So insulin levels, initially there is a post insulin level rises till we see the full onset of diabetes, and after the onset of diabetes, there is a gradual reduction in the insulin levels. But so the important aspect is that the beta cells, I told you, the 5 to 10 years before the onset of diabetes, the 40 to 50% beta cells are already lost, and it is a progressive destruction later on, even after the onset of diabetes. So here is our role as a primary care physician we can think of several aspects, the lifestyle modification, drugs, insulin, whatever it is. We have to motivate our patients to slowly, to delay the beta cell destruction if we can think of. Then at the level of blood sugar, initially there is a postprandial rise in the blood sugar even before the onset of diabetes, and later on the postprandial rise continues. Then the important aspects is the hepatic glucose production, which actually is normal till the onset of diabetes, but immediately after the onset of diabetes, there is a sudden surge in the hepatic glucose production. And of course, the postprandial the fasting sugar starts rising just before the onset of diabetes, but it is later on after the onset of diabetes, the fasting glucose continues rising. So this is the one of the important natural history of type 2 diabetes. We have to understand this phenomenon because this is very important for the management point of view. So the overall pathophysiological defects in type 2 diabetes is the beta cell dysfunction, of course, is the most important aspect which leads to insulin deficiency. But simultaneously, there are other aspects of hyperinsulinemia, which leads to high insulin resistance at the receptor level. There are incretin defects in the intestine. And there is a alpha cell, I told you, that leads to elevated glucagon secretion, also leads to type 2 diabetes. And kidney is very, very important site where the sodium glucose transporters are located in the proximal tubule, which reduces the reabsorption of glucose, leads to hyperglycemia. Then important aspects in the obese people is the decreased dopamine levels. Previously, we did not know this aspect. But recently, the understanding is that in most of the obese people, there is a decreased dopamine levels can also lead to hyperglycemia. And the adipose tissues, previously we were thinking adipose tissues as a very inert sort of tissues, but no, this is very important endocrine organ of our body, which secretes 30 to 40 enzymes and hormones, including leptin, including resistin, and several other adiponectin, and several other enzymes and hormones. So adipose tissue is very important site which can lead to hyperglycemia or type 2 diabetes. So dear friends, this is very important again aspects. If you want to understand about the beta cell dysfunction, if you see here, there is a insulin secretion is a very phasic insulin secretion. There are first phase insulin secretion, second phase insulin secretion, and the mean plasma glucose. If you do the oral glucose tolerance test, you can encounter this type of thing. So upper panel, if you see here, that includes the insulin mediated glucose disposal, and the lower panel includes the mean plasma glucose concentration during oral glucose tolerance test. And this is the very basic physiology of insulin secretion. Now I'll give you a little bit of insulin resistance, which is also very important aspects in type 2 diabetes. So liver and muscle both are involved. In liver, in type 2 diabetes, rate of basal hepatic glucose output is increased, and this is very important site for glucose production. And this overproduction of glucose occurs despite fasting insulin levels are increased in 2 to 3 fold, and it indicates the severe hepatic insulin resistance. So this is very important aspects of type 2 diabetes. Several drugs are available which can reduce the hepatic glucose output, including the metformin and several other drugs. In the muscles, and whether the patients are lean or obese type 2 diabetes, this is very important from Indian point of view, because we have encountered several lean diabetes patients also have the insulin resistance in the muscles. It is a primary site for insulin resistance. Multiple intramyocellular defects occurs which reduces the insulin action. Impaired glucose transportation, phosphorylation can be one of the important reason for the insulin resistance in muscles. And there is a reduced glycogen synthesis and again reduced glucose oxidation, which can also lead to increased insulin resistance in the skeletal muscles. Another important aspects of type 2 diabetes, please understand this phenomena that if you do the glucose tolerance here, the insulin levels here, and this is known as incretin effect. So this graph on the left side, which shows that this is in normal healthy subjects when we give the glucose stimulation, and immediately there is a rise in the insulin levels, and immediately after some times the insulin levels go down. But in type 2 diabetes, it is a flat type of insulin response, and that is known as normal incretin effects. This is in the normal healthy patients. But what happens in the type 2 diabetes, which we have seen the peak insulin response is not seen in type 2 diabetes, and the incretin effects reduces, and that is one of the important reason or mechanism for the type 2 diabetes here. Another very important aspects of type 2 diabetes is the paradoxical stimulation of glucose secretion in type 2 diabetes. If you see here in this experiment, what we have seen, insulin levels and glucagon. So there is an insulin level as either normal or little increase, but the glucagon level is paradoxically inappropriately elevated. And that is also one of the important reasons for type 2 diabetes. Another aspect of type 2 diabetes is the kidney. Tubular lumen and tubular cell border have the number of transporters. If you see here in the graph here, the SGLT2 are located in the proximal tubules. It is the most important is the sodium glucose transporter 2, and which is located in the lumen in the tubular cell. And what happens? There is a reabsorption is affected because of these sodium glucose transporters. When the reabsorption of glucose is reduced, then you most of the time, normally what happens? We do not see the glucosuria. But once the sodium glucose transporters are affected, we see the reabsorption is affected and lead to hyperglycemia. Dear friends, this is a very recent understanding of diabetes in obese people, because there is a decreased early morning dopamine levels usually observed in type 2 diabetes patients who are obese. So if you see here in the early morning, there is inappropriate rise in the dopamine level that also can lead to a hyperglycemia. Now, adipose tissues, what I told you just now. Adipose tissues are the important endocrine organs which secretes adipocytes, which secrete cytokines, chemokines, and that is the reason that affects then the liver. Again, the inflammatory cytokines and chemokines lead to destruction in also affect the liver, which ultimately causes pro-inflammatory and pro-atherogenic mediators. Again, through the skeletal muscles and kidney leads to atherosclerotic plaque. So this is one of the important site or the mechanism by which a cardiovascular disease or atherosclerotic cardiovascular disease occurs in type 2 diabetes. So if I can summarize now, what are the pathophysiological defects or features in type 2 diabetes? Very importantly, adipokine dysregulation, which leads to inflammation. Abnormalities in the gut microbiota. Again, a recent understanding that it is the gut microbiota which is now defective in type 2 diabetes can lead to more inflammatory markers and lead to destruction of type 2 diabetes or insulin resistance. There is an immune dysregulation by the inflammatory cytokines and the hyperglycemia, of course. So the organs involved, almost all organs are involved in the hyperglycemia. in the type 2 diabetes. It is the beta cells and alpha cells, liver, skeletal muscles, kidney, brain. Brain is again very important side where the neurotransmitter can be a defective, the amylin. So it is one of the important signs, and that's why few drugs are there which can treat the amylin neurotransmitter like the Semilin or amylin analogs. The small intestine, incretins are there, adipose tissues, the free fatty acids, and the heart, of course, the cardiovascular disease, the atherosclerotic cardiovascular disease. So, dear friends, there are several risk factors why the type 2 diabetes is increasing like epidemic proportion in the world and even in Southeast Asia. Even our Indians are very much involved in the prevalence or increased incidence of type 2 diabetes. So there may be a non-modifiable risk factors, there may be a modifiable risk factors, which lead to several defects in the body, including your genes, of course. It is a polygenic or heterogeneity is there. There is a mitochondrial dysfunction can also lead to diabetes, gut dysbiosis in the form of microbiota, inflammatory cytokines, reactive oxygen species, which can lead to increased oxidative stress, increased advanced glycated end products, ultimately lead to metabolic memory, and the most of the micro and macrovascular complications occurs because of this particular mechanism of action. So you have to remember this particular aspect, that why the modifiable or non-modifiable risk factors can lead to all the metabolic aberrations in the body. Dear friends, third very important aspects of the diabetes is the gestational diabetes. So what is the gestational diabetes? Any degree of glucose intolerance or diabetes diagnosed at the outset or during pregnancy. This is, but conventionally, we term the gestational diabetes, which can be diagnosed between 20 to 28 weeks of gestation. This is a very typical definition of GDM. Overall prevalence is 7%, but it is increasing day by day. Dr. Sheshayya's study, Dr. Balaji's study from Chennai, they have already seen that there is a sudden surge of increasing gestational diabetes in our country and all over the world also. So what happens in gestational diabetes? The hyperglycemia levels in the mother ultimately lead to extra glucose going to the baby, also causes hyperglycemia in the baby, and ultimately the baby with extra weight or macrosomia occurs. The important aspect of the gestational diabetes is the early gestational diabetes. This is the very recent aspects on the classification of gestational diabetes. Early gestational diabetes can be diagnosed during early pregnancy, even less than 20 weeks. Previously, we used to see 20 to 28 weeks, we see the gestational diabetes. But there are now few cases are there which can be diagnosed before 20 weeks. The prevalence in 41 studies, systemic meta-analysis says that the prevalence is around 0.7 to 36%. It is a wide range prevalence due to different diagnostic criteria, whether it is a DIPSI criteria, our own Indian criteria, or it is the international criteria. There are several risk factors for having the early gestational diabetes. It can be because of obesity, the increasing body mass index. There is a maybe previous history of diabetes mellitus in the females, and of course, family history of diabetes and multiparity can be one of the important reasons for increasing early gestational diabetes. So what happens when the gestational diabetes occurs? The outcome in the infants is actually affected. There are several cases where the macrosomia is very, very common in gestational diabetes. Most of the ladies require cesarean section. Induction of labor is most of the time the gynecologist has to induce the labor early. Hypertension, preterm delivery, shoulder dystocia, several other aspects of the birth outcomes are there. of course, we have to manage very diligently in the gestational diabetes right from the day one when we diagnose the GDM. We have to monitor the blood sugar levels, give the insulin, lifestyle modification. Of course, these days metformin is the drug of choice. And the other aspect of the GDM is even after the delivery, the postpartum dysglycemia is again very common. So we have to monitor the blood sugar levels even after delivery in the GDM mother. So identify the early GDM, what we can achieve. Early screen is very, very important. EGDM shows significant difference in clinical profile. Hence, sometimes it leads more than conventional GDM. Most of these GDM ladies are the insulin resistant. They encountered the hypertension, hypertriglyceridemia, perinatal mortality is high, even neonatal hypoglycemia is very common. So the need of the neonatologist after the delivery is very, very important. And most of the ladies need insulin for their management. So, and the postpartum, I told you, even after the delivery, they says that pooled prevalence of postpartum hyperglycemia or type 2 diabetes is around 5% and pre-diabetes is around 23%. And the relative risk compared to conventional GDM is very, very high. Then another aspect of the diabetes classification is the MODI. Again, Dr. Mohan and several other investigators are doing so much of great work in diagnosis MODI. What is MODI? It is a pure genetic basis of diabetes. So it is a monogenic diabetes exhibiting autosomal dominant inheritance. There is a single gene mutation has been found which can lead to defect in the beta cell. If you see here in the graph here, it is a glucokinase or the MODI2 is there where the genetic defect is there which lead to decrease in the glucose secretion through the insulin or PI granules. So manifestation, usually MODI occurs less than 25 years of age, but common is around 10 to 40 years of age. But we find in the little younger generation, this MODI. So there are different types of MODI has been diagnosed. But in India, commonly it is a MODI 1, MODI 3, and MODI 5. These are and MODI 2 also. So these are the MODI 1, 2, 3, and 5 are the most common MODIs we found in India. And also we have diagnosed in our own cases here in Rajasthan also we have found these type of. So these are the genetic modification of HNF alpha, or it is a glucokinase gene defect, or HNF alpha 1 beta, and there are several other gene defects have been found. So MODI 1 to MODI 14 have been diagnosed till date, and now more and more MODIs are being diagnosed. So this is the MODI. So how we can diagnose? There is a strong family history of diabetes in MODI, number one. They are mostly autoantibody negative. The lower than expected HDLC, antibody negative type 1 children has elevated C-peptide, a large increase in the blood sugar in OGTT. So this is how we diagnose the MODI here. And now if I can compare the type 1, type 2 and monogenic diabetes, the type 1 diabetes is in children less than 25 years of age, type 2 commonly more than 25 years of age, and monogenic again or MODI is around less than 25 years of age. Weight, as far as weight is concerned, type 1 diabetes are lean or less body mass index. Type 2 diabetes is usually they are overweight, but they can also be a lean type 2 diabetes in our country. Of course, monogenic diabetes are similar to general population. Islet antibodies usually present in type 1 diabetes while they are absent in type 2 and monogenic. C-peptide, again, there is a low or absolutely no C-peptide in type 1 diabetes. Type 2 diabetes, they can be normal or high, or in monogenic, normally there is a C-peptide is okay. Insulin production is absent in type 1 while present in type 2 diabetes. So first line treatment of type 1 diabetes is insulin. Type 2 diabetes, we can initially treat most of the type 2 diabetes patients with anti-diabetic drugs, but later on they also require insulin. But monogenic diabetes, MODY, depending on the different subtypes like MODY 3 or MODY 2, they can be treated with drugs, but most of the MODYs can be treated with insulin also. Family history of diabetes, usually infrequent in type 1, very frequent in type 2, and very strong family history is there in the monogenic diabetes. Decay is very common. Diabetic ketoacidosis is very common in most of the type 1 children comes with the decay. Type 2 diabetes, not very common, but in MODY, it is also rare. Now, dear friends, my last presentation is the cluster-based classification. This is the most important part, and this is the recent cluster-based classification. You have to remember this thing. So there are 5 unique clusters are there because now the treatment, the complications are depending on these 5 clusters of classification. The first important is the SAD, which is known as severe autoimmune diabetes, SAD. Another is the SID, severe insulin deficient diabetes. Third is the SIRD, which is severe insulin resistant diabetes. MOD, it is a mild obesity related diabetes. And fifth is the MARD, it is mild age related diabetes. Dear friends, this is one of the international cluster classification. Even Dr. Mohan has done our Indian clusters also. I'll give you just a little later. But please remember, dear students, this is the cluster-based classification, very important from the management point of view. We have designed a software recently with the help of Dr. Om Lakhani from Ahmedabad, which just put those some characteristics of the patients into that software. You can even diagnose all 5 clusters of diabetes. So Asian Indian phenotype, because we are little different as compared to our Western counterparts. So there is a sub-classification of type 2 diabetes for our own Indian classification, because it also, we are having a different phenotype. I don't want to give you details about all these things, but yes, we are little different as compared to our Western counterparts. So our own cluster classification is 4 basic major classification. The important thing, we are having SID, severe insulin deficient diabetes, which is around 26%. IROD, insulin resistant obese diabetes, which is around 25.9%. SIRD, it is combined insulin resistance and deficient diabetes, around 12%. And MARD is mild age-related diabetes, is around 35%. So there are different characteristics of these classification, these clusters. Why the new classification of cluster are there? Because several characteristics are there different, and then the management point of view, these patients require different management. Because if you see here, severe insulin deficient diabetes, they require insulin for their management. While in the combined insulin resistant and deficient diabetes, they can be very well treated by the insulin sensitizers and the anti-diabetic drugs. So there is one big study done by Dr. Mohan and other investigators, which clearly said that there is a greater risk of chronic kidney disease in IROD and SIRD, while retinopathy, nephropathy, and other microvascular complications are there with SID also and SIRD also. So dear friends, there is a definite advantage of having this newer cluster classification of SAD, SID, MOD, SIRD, and MARD, because ultimately your management depends on different. If you diagnose very clear one cluster of diabetes, then you can think of having a precision medicine or individualized medicine based on this cluster classification. So dear friends, just see here, if you diagnose the third is the cluster 3, then biguanides, thiazolidinediones, SGLT2 inhibitor, GLP-1 receptor agonists are the drug of choice for this third. For the mild, this is MOD, biguanides, SGLT2, DPP4, and GLP-1 receptor agonists. Because the most important aspect of management is weight control, diet, and exercise, while for MARD, for SID and SAD, it is the adherence, the clinic, the multifactorial therapies are or even polypharmacy is needed for this type of management of these MARD, SID, and SAD. So now, because of if you diagnose very correctly the cluster classification, then you can predict the complications of the diabetes, and you can even predict, manage your diabetes with the precision or the individualized diabetes. Dear friends, now summarized. Cluster-based classification is the recent classification you have to see with the pathophysiology, and it predicts the risk of diabetes complications. Cluster-based classification is very suitable for not only in the world, other countries, but very importantly for our own country. Understanding pathophysiology of diabetes is very important depending on the different classes of diabetes. So we can predict the metabolic complications and we can optimize the therapeutic strategies for different class of diabetes. Thank you very much for the patience listening. I hope this is very elaborate classification I have given to you, and I hope it will be useful for your post-graduation and even for your other examinations. Thank you very much. Hello. 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 Any questions? Anand? Anand?
Dr. Sanjay sir.
Yes.
Yeah.
Yeah. I'm here for the question and answer.
Said to put their questions in the chat book.
Okay. So most of the time I see the greetings here.
Yeah. so I also could not find any question.
Yeah, most of the time they are just the names and the greetings. And I hope Gudi Padwa is there, so there most of the people have greeted us and each other. So I don't think, yeah. But I think it will be useful for all of you. I hope so.
Definitely, sir. It is useful for us also.
So any question, specific question, I am here. Any specific question you want to ask? Because the last part of my presentation was the most important, the cluster-based classification.
Sir, is there any difference in treatment for the different types of MODY?
Yes, definitely. Like I told you, one of the glucokinase defect can be treated by the oral drug, sulfonylureas. But the other MODYs, they require the insulin for their management. That's why if we diagnose very specific genetic defect in MODY 1, 2, MODY 1, 3, and 5 specifically, these are the MODYs which can be treated by oral drugs. But for other MODYs, we have to employ the insulin for their management. And I hope the MODY genes, which is it's not commonly done in most of the centers in our country, but I know one of the important is the CMC Vellore and the Dr. Mohan Center in Chennai. Sometimes they give complementary genetic testing. If you can send the genetic sample to these two centers, sometimes they give you the complementary genetic testing. And once you diagnose very specific type, the treatment can be designed accordingly.
Sir, there is one more question.
Yeah.
That is, type 2 is insulin independent. Then in later stage, why insulin is used if not controlled on oral medication?
Perfect. I think this is what I was expecting. I told you during my natural history of type 2 diabetes, what the natural history says. Even before diagnosis, the frank onset of diabetes, 40 to 50%, even 60% beta cells are already lost. And because it is a progressive disease, the beta cells are continually, there is a apoptosis of the beta cells continuously occurs. So what happens at any one point of time or any point of time during your management of type 2 diabetes, initially your anti-diabetic drugs, there are two types of drugs. One is anti-hyperglycemic drugs and another is oral hypoglycemic drugs. So there are differences between these two types of drugs, but we treat with both insulin. I mean, the hypoglycemic drugs are needed initially because your beta cells are still working. So those sulfonylureas, meglinotides, they work very well during initial phase. But later on, once the beta cells are already destroyed or most of the apoptosis of the beta cells occurs, then what happens? You can treat with insulin sensitizers for some time. The insulin resistance can be treated, but ultimately, once you do not have insulin in the body, there are several metabolic aberrations occurs and you need insulin at that point of time. So it is a progressive disease. Beta cells are destroying. You need insulin at one point of time in management of type 2 diabetes in whole lifetime. Yeah. Can we give insulin along with OHA? Yes. Why insulin is needed? Initially, we give the basal insulin, once a day insulin for initiation of insulin, because we have seen in practical also and also in theoretical also that once you give very early insulin, it causes rest to the beta cells because the beta cells are destroying very fast. So once you give basal insulin or in the nighttime insulin, sometimes there is a rest to beta cells occurs. And because of this rest, some beta cells actually, if you go again with the molecular aspect of the beta cell physiology, most of the beta cells during the hyperglycemic excursion, some beta cells go into the just into the receptive phase, and some beta cells go into the permanent apoptosis. So those beta cells which are goes into the receptive stage, they sometimes become reactivated once the hyperglycemia becomes settled down. So insulin is sometimes needed along with OHA, and this is a very useful strategy we can employ in management of type 2 diabetes.
Very nice, sir. Since we are discussing some of the points in the treatment, I would just like to request you to make some comments on the diabetes remission.
Okay. So now this is very important aspects we are discussing these days. There are three aspects of diabetes remission. Remissions, what is the definition of remission? Remission means the diabetes can be treated without medication initially for 3 months and then later on also. So it is very difficult to have the remission, dear friends. This is very difficult. Of course, the other aspect, the reversal is again very difficult. We have not seen, there are few cases there which have seen the remission for few times. Like I told you, the beta cells, they are going into receptive stage. And once you treat the hyperglycemia initially, sometimes these beta cells rejuvenate and they become activated again. And in that case, your beta cell secretion occurs normally. And most of the people who have got the good lifestyle modification, yoga, we have recently published in Diabetes Metabolism and Obesity, our 4 years study on pre-diabetic, we have recently published. I can share with all of you. If you can write to me on my email, arvindgdiab@gmail.com, you will get my email. This paper, for the first time, 6 centers, including Dr. Chandalia, Dr. P.V. Rao, Dr. Madhu, Jyoti Dev, and myself, we have done the pre-diabetic population, followed for 4 years. And every 3 months, the diet, lifestyle modification, and different structured yoga protocol, then we can reduce by 46% occurrence of pre-diabetes conversion to diabetes. So this is what we have already proved. So lifestyle modification, yoga, and diet is one of the important aspects which you can think in terms of remission. So molecular remission is possible with these type of lifestyle modification. But long term, we do not have any concrete results at present. The publication, the long term remission is possible or not, we'll see into the future.
So many thanks, sir. So I think in the coming classes we will discuss the different aspects of the diabetes regarding the treatment and the preventive aspects. So most of the question that is coming is basically on the treatment aspect.
One more important is the immunosuppression. Yes, I can answer this very important question. Teplizumab is one of the very important newer drug, which is a monoclonal antibody in type 1 diabetes and some type 2 diabetes. The people are trying to use this teplizumab as an immunosuppressive drugs, or you can see it is a monoclonal antibody, and the remaining C-peptide or beta cells can be preserved by these newer monoclonal antibodies like teplizumab. This is an experimental drug, but yes, it is possible.
Thank you, sir. May I request Dr. Sanjeev Maheshwari, sir, for his comments? Probably.
Dr. Sanjeev, are you there? I think
he is not there. Okay.
Yeah.
Okay. So on behalf of ICP, I would like to thank sir, Dr. Arvind Gupta, sir, for the brilliant presentation on the diabetes classification and the related matters. So it is very useful in order to make the treatment of the diabetes more comprehensive and more reliable. So we have learned a lot of things. Thanks are also due to our Dean, Dr. Kamlesh Tiwari, sir, for conceiving such a brilliant idea of short certificate courses on the different aspects of medicine. So he deserves our thanks, and thanks are also due to API president for always encouraging us to do all these things. So many thanks, and on all the students need to be encouraged to take part in the classes regularly. So I must congratulate and greet them for attending the classes. So many thanks, sir. Next week we will discuss some other aspect of the diabetes. Thank you, sir.
Thanks a lot. Thanks a lot.
Thank you, sir. Thank you, sir.
Bye.
Bye.